Maintenance therapy is used to help keep myeloma under control for as long as possible after initial treatment, often with lower intensity dosing designed for long-term use. For many years, lenalidomide was the gold standard for maintenance therapy. Today, newer options are being added, most notably Daratumumab, either alone or in combination. In this video, we'll walk through the typical doses of drugs used in the maintenance setting and explain how they're given over time. What are the typical dosages of maintenance therapy?
The dosing of daratumumab as a maintenance therapy is the same as that of induction. It is a flat dose. It does not change whether it was when you were first diagnosed or after your transplant or during maintenance. So the daratumumab dose will always remain the same. When you first start daratumumab, we started a schedule that is a little bit more inconvenient, I suppose, but I equate it to filling up your cup. Right? When you are first getting treatment, we want to fill your cup up of that medicine, fill you up with that drug that it can really do its job to get to killing. So in the beginning of daratumumab, the doses start at weekly, where you get 1 shot per week for 8 times or 8 weeks. It then transitions to every 2 weeks, and it's every 2 weeks for 8 times or a total of 4 more months. After that initial 6 months, it transitions into once per month. And this process can be interrupted for a transplant and picked up on afterwards. And we are now, like I've said before, kind of keeping a lid on this thing, where now you don't need as much of the buildup of that daratumumab, you just need a maintenance. So you just get 1 dose of it at that fixed dose once per month. And in theory, indefinitely. There's some of the trials I've looked at using daratumumab for some fixed duration, whether that's 2 or 3 years, for example, particularly when combined with lenalidomide and then maybe dropping the daratumumab, continuing on the lenalidomide, but once a month is the dosing of it. Now, the lenalidomide is a little more challenging, but maybe a little more flexible, we'll say. There are a variety of different doses, and this is very individualized to some degree. When patients are first diagnosed, we have a standard dose that we start off with that can be changed based on a patient's most likely kidney function more than anything else. So let's say the starting dose is 25 milligrams. This is a dose of a pill that you would take for once a day, let's say 2 to 3 consecutive weeks in a row, followed by a week break. There's been some variety in different trials in terms of if they did 2 weeks or 3 weeks, but to keep it easy, 3 weeks is common. So it'd be 21 consecutive days out of 28 days, a 1 week break. And the point of that break is to they do exactly that. Give your body, give your blood levels a break from it to let everything kind of recover so we can get back at killing again next month. So the dose before transplant, as example, is really defined to try and get as high of a dose as we can that your body can safely tolerate so we can kill as much myeloma as we need to. After a transplant, the purpose of the maintenance lenalidomide is maybe not to kill as much as it is to maintain. And if that's the case, we don't need as big of a dose. Also, a lot of patients have side effects that they're still recovering from perhaps after the transplant, and we're not trying here to make people feel worse after a transplant. We're trying to do well by their myeloma. And so the maintenance starting dose for your average patient with myeloma is about 10 milligrams after a transplant. This usually starts somewhere between 2 to 3 months after the transplant when we think your body's had adequate time to recover and you're feeling back at it, just finally getting back to life before we say, hey, let's start something back up again. But the lenalidomide dose is about 10 milligrams as standard. Oftentimes this is continued when given by itself every day, no breaks. So I think of it as a pill a day to keep the myeloma away. Now, if you combine it with something else, you probably need that week break back in there again, where maybe you do 3 weeks in a row and a week off, just to let your body kind of recover from the side effects of having 2 drugs together that may have some overlapping toxicity. So 10 milligrams is our starting point. Some of the trials had designed it that you do 10 milligrams for 3 months and see how things go. You got brand new baby stem cells in there that are now trying to kind of grow their blood, and here we are kind of putting a little lid on them sometimes as a side effect of it. Some people develop low blood counts and they need to have their lenalidomide dose adjusted. Some people's kidney function may need it to be adjusted. Some people have fatigue. Some people have diarrhea. There's lots of different things that require dose adjustments because our ultimate goal is to keep you on this medicine. So if we can keep you on the drug, we can probably do better by finding a dose that's more tolerable for you. So the maintenance drugs, the maintenance dose of lenalidomide is 1 pill per day for either 3 or 4 weeks each month at 10 to 15 milligrams, which is different from the starting dose of 25 milligrams. So we hope it can be tolerable for the longer run.